let's go on to the cases. So in total, there's 5 cases that I've seen recently, and they're all of rectus femoris injuries, all in footballers as well. And so let's dive in. The first patient is a 21-year-old footballer who developed very significant proximal right leg pain when he was kicking the ball. He's actually a professional footballer, and there was pain at the end of movement. He said he felt this popping sensation in the anterior aspect of his thigh, and it was so significant that he wasn't able to walk properly afterwards. There wasn't any significant bruising or swelling. There was ongoing pain with hip flexion, and he had this throbbing feeling at night as well. When I examined his hip, he had significant pain over the proximal rectus femoris, and he had limitation on resisted hip flexion, and also when he bent his knee, there was it also caused the pain to exacerbate. Because I have the benefit of a very fine ultrasound machine sitting in my clinic room, I undertook an ultrasound of the injured side, and what you can see here on the ultrasound is this hyper-echogenic change in the rectus femoris muscle. So just to orientate you, this is the fascial planes of the rectus femoris. We're looking at it in a short axis orientation, and if you compare it from the uninjured side, the left side to the right, you can see this hyperechogenic change in the rectus femoris muscle, and it's sort of sitting around that sort of central tendon area. As you move distally, you can see that it sort of follows that central tendon area as well. And if you look at it on the long axis orientation, so at the bottom here on the left of the image, we're heading towards the knee, at the right we're at the hip, and you can see the muscle belly here, and it's nice and dark. There's plenty of fluid, and you know, it's looking very healthy, nice pennation angle and everything to the muscle. And as we come proximally, you can see this disruption starts to occur, maybe about in the proximal third. And then as we come towards the tendon area, it becomes very bright, hyperechogenic, and it looks like it's involving that muscular tendinous area. So because of the concern about his, the central tendon, and because of his the impact that it had on his ability to mobilize, not let alone place football, we organized an MRI scan for this boy, and it confirms what we saw on the ultrasound, that there was a acute partial tear of the proximal myotendinous junction. There was strain of the posterior lateral aspect of the rectus femoris, and the tendon origin was actually okay, so there wasn't an avulsion noted. Because of various sort of limitations on seeing him, it was decided to deal with this conservatively. But this did take a number of weeks to settle down and get better, even with daily rehabilitation and so on. So if I recall, it took about sort of 8 to 10 weeks for him to get back to full contact match play. So there was a bit of a delay in his return to play. Okay, so the next one is also a professional footballer, 17-year-old at this age. They're going in from the academy to the first team. He's right leg dominant, and he developed, again, right quadriceps pain with training. In his case, there wasn't a specific incident. It was just more that there was pain and tightness and everything in that area. But he started to notice that he was having pain with kicking and running and all the movements involved in soccer. When I did examine him, however, I did find that there was this prominent swelling to the right rectus femoris, and given the fact that there was no history of trauma or anything, he just started to notice this. I was initially worried about something a bit more sinister, as you can imagine, in the muscle, especially at this age. And he also had some pain with squatting. When you compare the injured side to the uninjured side, again, with the normal rectus femoris, you can see the nice fascial planes, you can see the muscle belly, and you can see the kind of normal hypoechogenic change of the muscle. And then when you flip over onto the injured side, you can see this huge diffuse hyperechogenic change emanating from the posterior sort of half of that muscle, and it sort of extends kind of anteriorly as well. There's also loss of that normal boundary of the between the rectus femoris and the vastus, and so it's really sort of the whole kind of hyperechogenic change has obscured the normal echo architecture of the rectus femoris. And you can also, it's not, I haven't measured the things here side by side, but you can see that the right side looks somewhat thicker than the left. When I looked at it in a long axis orientation, that's when you start to see some evidence of the tearing in the muscle, and in some ways that's somewhat reassuring because we're not thinking about something more like a tumor in the muscle, but you can see that there is some injury, and you can see this hyperechogenic change is quite diffuse in the body of that rectus femoris. If you go a bit more distally to the left of the screen, you're sort of coming back to normal muscle here, but you can see it's quite extensive. Again, we organized a MRI scan for this, and what it showed was that there was a partial tear of the ventral fibers of the indirect head, and there was this big hematoma sort of sitting in the muscle. The deep fibers had actually got injured and had kind of flipped over as well, and then there was edema and everything sort of spreading throughout. Again, with this player, the club opted for a more conservative approach, and it did again take him a number of weeks to get back to sport, although he did, and he's doing fine now, but it did take a quite protracted period, and he lost quite a large chunk of the season as a consequence. Okay, case 3. Case 3 is a slightly older footballer, so he's 28 years old. He was in the midst of a training session, and he was kicking the ball quite firmly when he said that he suddenly got this pain in the left quadriceps. There was no significant swelling or bruising to note, and this had happened like a week or two prior to him presenting. So the team had been sort of managing this conservatively for him, but because the symptoms weren't resolving, and actually it was getting worse every time he made contact with the ball and so on, it was decided to bring him in and for us to have a look. So here, instead of just still images, I got a little video of his ultrasound. And as you can see here, as we're scanning through, there's a disruption of the muscle. Let me play that one more time. So you can see this hypoechogenic area here in the muscle with a hyperechogenic sort of area surrounding. And here you can see there's separation of the fascial planes, there's disruption of that muscle, and there's this hyperechogenic change which suggests bruising or bleeding in the rest of the muscle. Okay, so again, with him, we got an MRI scan of the leg, and in his case, there was a tear of the indirect rectus femoris over the lateral aspect, with effusion between the two muscle planes. The tear was quite extensive, 21 centimeters long, and this really sort of helped us understand why he was having the symptoms that he was having. In this case, because of the the level that he was playing at, and because of the importance the role he played in the team, it was decided that we would undertake a PRP injection for him. So we basically I anesthetized the superficial layer of between the fatty tissue and the rec fem, and basically took little aliquots of PRP and just sort of fenestrated it through the muscle, through the area of the injury. He actually had a very good response to it. Within about within less than a week, he had a significant improvement in his pain symptoms, and he was able to get back to playing full contact football within about between 3 to 4 weeks. So actually, he did pretty well as all things considered. That he'd been out of action for about 2 or 3 weeks prior to coming in. Okay, moving on to case 4. We have a 31-year-old footballer who developed pain in the right quadriceps with training. He said that it came on with again striking the ball. There was he had this feeling of instability in the leg because of the pain, and again there was quite localized swelling over the rectus femoris. He didn't have any sort of low back issues or anything like that, given the fact that he was having the issues of weakness in the leg as well. And on examination, there was a significant swelling to the right quadriceps, and there was pain again with palpation and stretching. When I did the ultrasound for him, now we don't have a side-by-side comparison. This is a short axis view of the rectus femoris and a long axis view. But you can see in his case, you can see the boundaries of the rectus femoris muscle, the upper and the lower fascial planes. This is fatty tissue and skin up here. And then in the middle of that rectus femoris, you can see this hypoechogenic change with this hyperechogenic change surrounding it, which is basically suggestive of it's got a hole basically in his rectus femoris, for want of a better description. And this was compressible, so there's still hematoma and everything sitting in there. When you look at it in the long axis orientation, you can see the normal sort of pennation angle of the muscle here, and you can see that it's quite significantly disrupted around this injury area. So it's right smack in the middle of his rectus femoris muscle. And again, for completeness, we organized an MRI scan, and there was a rupture of the direct fibers of the rectus femoris at the mid to distal thigh, with measuring about 1.1 centimeters. It was around the myotendinous junction, and there was this sort of feathering, there's bruising and swelling sort of extending from there. In his case, we also did a PRP injection. So here in the first video, I don't know if you can see the needle, but I'm popping a little bit of local anesthetic into the tissue plane between the rectus femoris and the subcutaneous fat. And then in the second one, I've already aspirated the hematoma, and I'm popping in the PRP into the area where the gap was. So just as I'm withdrawing, I'm injecting that PRP. Again, with this player, he had a significant improvement in his pain symptom within a few days. He also was able to get back to playing full contact within about 3 to 4 weeks. I mean, we offloaded him for the first week. Second week, he went back into kind of rehab, and by the end of this third, fourth week, he was back to full contact, and honestly, he hasn't looked back since then. So he's done remarkably well. Okay, last case is a 16-year-old footballer. Now, this young man is not a professional, but he loves football, and he loves athletics and running, and hard to pin him down. So he is a 16-year-old who basically had a 1 to 2 month history of this vague quadriceps pain. It came on while he was, sorry, it came on with soccer. Sorry, I got a typo there. It came on with soccer, and he didn't really tell his parents about it. So he just basically, manned up and carried on playing sports and doing everything. But unfortunately, he was hoping to take part in a cross country, and as he started to increase his training for that and running for that, his symptoms started to get worse. And so when he came to see me, he had this significant swelling over his thigh, and there was also some bruising in the surrounding it as well. On examination, there was this firm swelling in the left rectus femoris, and it to me, sort of, on palpation, it looked like it was about 5 centimeters by about 10 centimeters. Again, looking at it on the ultrasound, so here we have the left rectus femoris and the right. So on the right, again, just to orientate ourselves, we have the fascial planes. We can see, I mean, he's a fairly skinny chap, so there's not much adipose tissue. You can see the fascial planes of the rectus femoris. You can see the femur down here, and you can see the VI just beneath it. When we look at the left side, again, you can see the fascial planes, but you can see, again, this significant hypoechogenic change within the substance of the rectus femoris. You can see a hyperechogenic surround and loss of that normal architecture of the rectus femoris. Also, you can say that there's significant thickening and swelling, and with the same settings on the ultrasound, whereas you can see down to the femur on the right side, you really can't see anything beyond that vastus intermedius on the left. In the long axis, you can see the real extent of this injury. So although the hypoechogenic change, the physical, the hematoma and the tear is only this much, you can see that the muscle has got disrupted all the way from number 1 here to this plus over here. So it's quite an extensive area of hematoma and bruising and injury to the muscle. And you could argue that it almost takes on a bit more of a fusiform sort of change in that muscle because of the hematoma that's sitting in there. Again, I think this is a video just to show it in short axis. So again, hyperechogenic change. Basically, you can see this gapping and how extensive it is. It's basically, going through that muscle, and it goes from the posterior border into that sort of central portion as well. So on his MRI, there was a significant rupture to the indirect fibers of the rectus femoris. Again, quite a significant tear, 16 centimeters, and it was really sort of causing him some bother. And yeah, so again, in this young man, what I did was I aspirated that hematoma. We used I used an activated form of the PRP so that it stayed within that space, and lots of compression, physiotherapy afterwards, and I'm pleased to say that he's again back to sport, and he's doing very well. So let's think a little bit about muscle injuries. And when I was thinking about what to cover, I thought maybe we can have a look at, a little bit about go back over the classification a little bit, talk a little bit about rectus femoris injuries in football, and maybe touch upon the management if we have time. So over the years, there's been various classification systems proposed. As far back as 1962, O'Donoghue came out with the 1, 2, 3 grades. So number 1 being obviously no significant functional loss or appreciable tissue injury. Number 2 being some, and then number 3 being a complete tear. And then 7 years later, there was another iteration of this. In 95 and 2002, there was another iteration. And as we come into the sort of MRI era of medicine, then we start to have more imaging-based things, which is, more based on the percentage of muscle that's been injured and so on. But quite often is the case that, although we do have these, the grades 1, 2, and 3, what does it also mean sort of clinically, and where do we go from there? More recently, over the last 10 to 15 years, there have been 5 papers that I came across published on muscle injuries. Now, each of these try to deal with the quantification of the injury and what the impact is afterwards. 2 of them actually deal with hamstring, but it's still sort of relevant. And then the others deal more with muscle injuries in general. So the Cohen paper, hamstring injuries in professional football players, and they used the MRI imaging with a correlation to return to play. In this paper, of course, they looked at hamstring injuries, but they looked at a number of variables which were quite interesting, I think, and maybe can be applicable to other muscles. But of course, we have to take it with a pinch of salt, because they were looking specifically at hamstring, and they were looking at American football. So in addition to the variables such as the number of muscles involved, the location, whether there was an insertion in involvement, the cross-sectional area, the retraction, and the long axis sort of involvement, they looked at how long this player was out. They looked at what position they played, what playing time, and so on. And then they attributed a score to all of these things and said, this is the sort of grading of the injury. And, for this cohort and for this study, clearly it was relevant. But the relevance and the ability to extrapolate there to other injuries, such as the rectus femoris in these cases that we've seen, may be somewhat limited as well. Then there was another paper by Otto Chan, who is a very senior consultant MSK radiologist in the UK. And I don't know if any of you recognize the name Nicola Mafuli, but Prof. Mafuli is a well-known orthopedic surgeon who's done lots of work on Achilles and tendons and so on. And so they got together and they did this other classification on muscle injuries, but based on a more sort of anatomical focus rather than necessarily grading. But then they tried to take it back to the 1, 2, 3 grading. So what they started to go down into was the areas, and so whether it's proximal muscular tendinous, the proximal third, middle third, distal, and then they started looking at whether things were intramuscular, myofascial, myotendinous, or whether there was a more combined sort of look at things. Again, when you're one of the limitations that they talk about in their own paper is that although they have delved really down into the nitty-gritty in terms of the anatomical location of the tear and the size of it and so on, what does it mean in terms of practical terms and clinical relevance? They do have some examples of their injuries. So a grade 1 showing the sort of diffuse signal in the muscle, but without any significant gapping. Grade 2, a little bit more diffuse and maybe a little bit of fiber disruption. And then grade 3, quite significant disruption of the muscle and so on. So they do try and kind of come back to that sort of grade 1, 2, and 3 approach. But they started to talk a little bit more in detail about the absolute location of the injury. Then came along the Munich consensus statement, which was kind of led by Müller-Wohlfahrt, and many of you probably have looked at this, familiar with it, but they started looking at things from a slightly different aspect. They started talking about direct and indirect muscle injuries, whether things were based on a functional issue or structural, and then they started to incorporate other things such as the fatigue induced and so on. So let's have a look at their sort of classification in a bit more detail. So this is the whole table of from the Munich consensus. The first half looks at the more functional things. So is this a fatigue-induced muscle issue where there's, just increased tone, and what are the clinical findings that you might see? Is this something like you've been to the gym and worked out a bit too hard and you've got delayed onset muscle soreness? So, just generalized muscle pain with, especially with sort of eccentric movements. Is there a spine element to things? So, is this throughout the muscle, but there's something going on elsewhere that's causing the symptoms? And then, is there an issue with the sort of whole kind of neuromuscular function? Is there a dysfunctional issue in the muscle that is contributing to it, and as a consequence leads to cramping and so on? So they've put all of this into that whole classification system with the muscle injuries as well. The second part of the table starts to look a little bit more familiar in terms of the muscle injuries. And of course, we start off with the more minor ones where there's relatively insignificant tearing of the muscle in terms of the diameter. There's significant pain. The athlete might feel a sort of snapping feeling, but it's relatively well defined. With the more significant injury, the moderate partial tears, the tear is of a more significant diameter, maybe more than a muscle fascicle. There's a significantly more pain, but still relatively well defined. So they have the 3A, 3B as the kind of mild and moderate, and then the significant, the bigger tears they put as grade 4. So much more extensive injury. There's pain even when they're not doing anything, and there's a significant defect in the muscle as well. And lastly, they put as an added thing the direct injury, so the contusional. So when somebody's had a direct impact on it, what are the they've put this as the last kind of category. So these are the injuries that they put in their classification system in a more graphical view. But if we look at the muscle injuries, how they have talked about it, the 3A, 3B, and the 4. So they're focusing on these kind of, the muscle belly. Is there a significant tear? Is there, has the muscle kind of ruptured and so on. So they tried to be a lot more comprehensive in what they included, but I also feel that they didn't really revert away too much from the classic 1, 2, 3, but they incorporated other things that are relevant, but not necessarily muscle injuries in the sense that we may see in clinical practice. Later, in the British Athletics medical team. So Noel Pollock is currently the head of British Athletics Medical. Robin Chakravarti was there as the head, and then he moved on to football. And sorry, I digress. But they basically started their own sort of classification system because they were seeing a lot of muscle injuries in the athletes that they were looking after. And so they put together this table. And so at the kind of grade 0 is basically everything's normal on imaging, and they really focused on the imaging side of things here. And it's usually grade 1 is usually grade 0 is usually after you've gone out and you've done a run and you're not used to doing so, or just after exercise. Grade 1, so grade 1 is there's minimal change in the muscle belly, so less than 10% extension into the belly, and there's a very minimal sort of signal change in the muscular tendinous junction. So they gave the A and B according to whether it's myofascial or whether there's tendon involvement. For grade 2, then they split this further into myofascial, muscular tendinous, or intratendinous. And basically, as you're going through each of these areas, the area of injury gets more compared to grade 1. The area of signal change also gets more as well. And it just depending on the location in the muscle, then it goes from a 2A, B, or C. Grade 3, again, is in keeping with what we traditionally, the original sort of classification of muscle injuries, where there's very significant signal change, more than 50% at the area of injury, and a greater distance of the injury as well. And as again, with grade 2, it's either in the myofascial area, it's in the muscular tendinous, or it's in the intertendinous area. And then grade 4 is basically where there's a complete disruption of that muscle. But the main thing is with the retraction of the stumps. So is there a significant disruption, and has it been pulled away from each other? And in which case, then you can start to call this a grade 4 injury. Okay. The last article on the muscle injuries and classification is by the Barcelona football medical team, led by Valle. And again, this one looks at more at the kind of hamstring issues than other muscles. But because they were seeing a lot of hamstring issues, they started to look into this a little bit more. So the first part really is about where in the hamstring the injury is located, if it's a direct or indirect. So you can see things that are slightly akin to the Munich consensus here, and they also based it on MRI sort of findings as well. And then in terms of the grading, again, they went back to the 1, 2, 3, 0, 1, 2, 3. So on the grade 0, there's nothing on the MRI, and then as we go through the grades, there's increasing edema, there's increasing disruption of the muscle, and eventually there's a bigger area of damage. Okay, so I was looking back at the in cases that I've described, and I was thinking maybe I guess it's not so interactive here, but maybe we can just go through the injuries again. And according to the British Athletics injury consensus, we can try and grade the injuries. So the first one was an acute partial tear of the proximal myotendinous junction of the right rectus femoris. So to me, that would be a 2B. So just to remind yourself of the images. So we have injury to the muscular tendinous junction. There's no injury to the attachment, and it's not sort of extending through the rest of the muscle as well. So case 2, partial tear of the ventral fibers of the indirect head of rectus femoris muscle. I put this down as a 2A. So again, we have disruption of the muscular intermuscular septum and between the sort of rect fem and the vastus, and but there isn't any involvement of that central tendon area, and there's no involvement of the attachment. Although there is some gapping, but it's not a complete rupture. So, well, I guess you could say is this a grade 2 or a grade 3? Maybe actually, thinking about it, maybe a 3A. So happy to discuss this later on in the Q&A section. Next one is a tear of the indirect femoris muscle with lateral-sided subaponeurotic fibers with intramuscular plane effusion. So again, I put this down as a 2A, mainly because there wasn't a significant gapping of the muscle, but there was definitely some sort of disruption at the plane as well. This is probably more a mixed sort of injury because of the diffuseness of it. So yeah, I guess for me, maybe 2A, but open to debate again. Then rupture of the direct fibers of the rectus femoris at the mid to distal third centered on the myotendinous junction. I gave this down as a 3 because there was a significant disruption of the muscle. There's this hematoma sitting there, and it's focused in on that sort of myotendinous area. And lastly, rupture of the lateral indirect fibers of the rectus femoris at the mid to distal thigh. Again, a grade 3C, again, because of the extent of the injury, but also because of the location of it as well. Okay, moving on swiftly, let's have a quick think about rectus femoris injuries, particularly in football. There was a very nice paper that was written by this group some time ago, and they looked at some of the clinically sort of relevant issues around why footballers develop rectus femoris injuries and the types of injuries that you can get. So typically, it's either from an eccentric loading of the rectus femoris muscle that happens either during sprinting or when they're kicking the ball. It's in the sprinting, it's usually if there is a acceleration, so they're kind of in the swing phase of the movement, or it's either or it's in the deceleration when there's a change of direction and they're planting the foot and suddenly pushing off to go in a different direction. With the kicking, it's usually with the ball contact, and there's the high contractile forces to strike the ball, or it can be during the swing phase as they're sort of stretching back their leg and they're winding up to sort of kick the ball. But sometimes it can happen with ground contact. Say they either they miss the ball, they kick their foot into the ground, and there's a significant sort of deceleration, or when they're blocked. In terms of the risk factors, they describe it as intrinsic and extrinsic. The main extrinsic one being a very, very dry pitch, where if the foot gets stuck and they're moving, there'll be that sort of eccentric loading of the muscle. But in terms of intrinsic, there's the age. So as we get older, we tend to have a higher incidence of all these sort of injuries. If there's been previous trauma, so if I take you back to the 16-year-old that we saw, he'd had some issues for a while, and then suddenly something got worse, and then he came in to see me. So he'd had a subtle injury up to that point, and hadn't recovered from it. And then by the time he developed a more significant one, that's the time that he came to see us. If you have a short height, if you have an increased BMI, if you're not so flexible, and if you're not so physically strong, all of these are also intrinsic risk factors towards developing these rectus femoris injuries. Then another paper looks at the management of this, of rectus femoris muscles, and there's a bit of a practical sort of guide in terms of it. So what this paper talks about is that the majority of these injuries are around the sort of central septum. At the beginning of hip flexion, so as the hip is being sort of flexed, you tend to have issues with the direct tendon. Once hip flexion has begun and you're kind of going through that movement, it tends to be involving the indirect tendon. They also discuss some of the possible consequences of not dealing with things properly, so the risk of myositis ossificans, and one of the differentials, of course, for a swelling over the quads is Morel-Lavelle lesion, so from contact injury and fracture of the fatty tissue. They give a very nice diagram in terms of how to go about managing these things. And so they talk, if it's like a contusion, whether you aspirate it, if it's Morel-Lavelle, how you deal with the sort of myositis, if there's injury to the tendons, if there's injury to the sort of mid-substance of the muscle as well. So it just gives a little bit of more of a schematic in terms of how to approach things. Okay, just gonna touch base a little bit on the management. So there was this paper by Begum and Faris Haddad is a very eminent sort of hip surgeon in the UK as well. Justin Chang is a radiologist, I think. And basically, they were talking about the management of rectus femoris avulsion injuries. So, of course, if there's an avulsion, if a bit of the bone has been pulled off, and there's the patient is somebody who's got kind of high functional demands and so on and so forth. Of course, we go for a more surgical approach in terms of repairing that area, or if it's somebody who has persistent pain with a functional sort of compromise. Now, of course, none of the cases that I went through had any issues with avulsion, so we'll just skip over that now. The next thing is when there's an intrasubstance. Now, of course, the traditional thing is to kind of take a more conservative approach. Go for physiotherapy, rehabilitation, apply price, and so on. And then we come on to the controversy of PRP. This paper that was undertaken by our colleagues in Malaysia, they looked at PRP for acute muscle injuries, and they basically said that in this paper, Wright and Carpenter, they looked at they did a small trial in professional sort of athletes, and what they said was that time to recovery was shorter than in the control group, and there weren't any significant effects of treatment. Now, I went and pulled up that paper, and when we have a look at it, yes, indeed, they say that there is a significant improvement in the recovery time. The treated group was 16.6 days, and the non-treated or control group was 22 days. They also did MRIs, but actually in their control group, they still used something, Tromil or Actavegan, and I don't know if any of you have experience in using this. This was something that was very popular in the UK some time ago, and it's basically like a I would describe it as a supplement, and it's a kind of it's something that you inject in to try and help with the injury, but it's not an absolute control. So there is a little doubt in my mind as to how strong the evidence is with this. However, one of the other things that I have started doing with these muscle injuries is using elastography to complement clinical assessment in terms of after treatments and for recovery and so on. So ultrasound elastography, for those of you who have dealt with kind of tumors, liver tumors or breast tumors and so on, is where the ultrasound probe but there's two types of elastography. One is you compress the tissue to see the recoil of the tissue. The other one is where the ultrasound probe sends a sound wave into the tissue, and then depending on the reflection back of the sound waves, it tells you the nature of the tissue. So it's used a lot in liver and breast cancer to identify abnormal tissue compared to normal tissue. However, in muscle injuries, sorry, this is the example of the liver. So you're looking to see if there's a hot spot on this liver scan to identify where the tumor may be. But for muscle and musculoskeletal ultrasound imaging, there isn't any sort of normal ranges, as it were. So what I've adopted is basically comparing one side to the other to see how the injured side is deficient in terms of muscle tensile quality compared to the non-injured side. So if you remember, we had this player who had this basically hole in his rectus femoris. And so as he was recovering from it, and as you can see, things are starting to fill in here and so on, I use the elastography to gauge how significant the difference was in terms of the muscle tensile qualities. And actually, we use that as well as his functional and clinical sort of findings from the physiotherapist to guide his return to play. And so one of the things that we look at is this is the median reading for the elastography, and basically as the muscle recovers, it gets closer and closer and closer to the non-injured side, and we can use that as a surrogate measure of the sort of healing as well. Now, I've used that in all of the cases that I saw with these rectus femoris injuries, and it has been incredibly helpful in terms of guiding the rehab and gives a bit of a feedback for the physiotherapist as well in terms of how the athlete is progressing.